Good morning, everyone. Can you hear me online? So we are having a few in-person attendees coming in, but we're going to go ahead and get started. So welcome, everyone, to Cardiology Grand Rounds. My name is Chris Longenecker. I'm the director of the Global Cardiovascular Health Program, and we certainly have a treat today for our first annual Global Cardiovascular Health Visiting Lectureship. It is not yet a named lectureship, so if there's anyone in the crowd or anyone on Zoom who wants this to become a named lectureship, please let me know and we'll make that work. I want to acknowledge that we are living in uncertain times for global health, for research, and we don't know what will happen tomorrow. We don't know what will happen today. But what we do know is that we're very privileged to be working in a field with colleagues that are incredibly mission-driven, that are just great people to work with, and it's that we take a lot of comfort in that now, and we are here to support each other. So I'm going to introduce our Grand Round speaker, Dr. Rajesh Vedanthan from NYU. He's the director of the section for global health at the Institute for Excellence in Health Equity and associate professor at the Department of Population Health at NYU Grossman School of Medicine. Dr. Vedanthan went to medical school at UCSF in San Francisco. We were just chatting about Waymos and driverless taxis. He then came across the country to the Brigham and Women's Hospital, where he was a resident in internal medicine, and then to Mount Sinai in New York City for cardiology fellowship, which is where I met Raj back in 2008 when I was interviewing for cardiology fellowship. Raj was an early adopter of implementation science and had the privilege of really coming up through the ranks early in his career there with Dr. Valentin Fuster, and did a lot of great work in implementation science with a group in Kenya called AMPATH Kenya. You'll hear a little bit, I think, about his new effort to replicate the AMPATH experience in Ghana. Dr. Vedanthan is internationally recognized for his work in the field of global cardiovascular health, with over 200 publications, many grants, and we'll go into much detail, but he's also very recognized as an excellent teacher and mentor, and we're just really privileged to have you today, Raj, and so it's all yours.
Fantastic. Thank you so much. I just want to make sure you can all hear me with the AV. Okay. I wanted to thank you, Chris, for a very generous introduction. Problem with very generous introductions is that it's all usually downhill from here. But thank you so much. And it is true that, and I will be talking about this later, that one of the nice things about this work are the friendships that are developed. And so it's very nice to be able to reconnect. And we've been connecting actually over the last decade and a half, which has been very nice. It's obviously in person. I think folks can come forward. Don't worry, I won't bite. So feel free to move closer to the screen if you wish. I'm happy to be here today and honored actually to be here for the inaugural Global Cardiovascular Health Grand Round. So thank you so much for the invitation and to the leadership for inviting me as well. I'm here to present to you today on some of the work I've done ranging from cardiovascular care delivery to climate cardiology. So let me just go ahead and get started. No corporate disclosures, but these are some of the federal and foundation grants that I may refer to during my presentation today. And I wanted to start first actually with just a few cautionary words on the practice of global health. And it's actually an interesting time to be making these comments in terms of many of the changes that are occurring that we're all aware of. But there has been, the reality of global health is that it was born out of the history of colonialism and the sort of like more modern version of colonialism that the world experienced over the last couple of centuries. And the reality is that even today's practice of global health still carries some of those vestiges of that colonial history, whether it be power differentials, whether it be violence, whether it be forced displacement of populations, et cetera. And so I think it's important for us those of us who work in global health to really try and disentangle ourselves from that history as we obviously move forward in the practice of global health. One of my colleagues and friends, Madhukar Pai, in McGill University, has written a lot about this topic. And I just wanted to share a couple of paragraphs from a blog he wrote a few years ago. Imagine this scenario. And actually, it's good because I think several fellows are here. So it's in a way sort of good for the trainees. Imagine this scenario. A couple of newly minted Master of Public Health graduates from an African university, say in Rwanda, land in Washington, D.C. for a 2-week visit. They visit a few hospitals, speak to a few healthcare workers and policymakers, read a few reports, and write up a nice assessment of the US health system with several recommendations on how to fix the issues they saw. They submit their manuscript to the American Journal of Public Health. Can you imagine the journal even sending it out for review? Even if the paper got published somewhere, would US health researchers take it seriously? And then he puts in parentheses, they should, I suppose. After all, the broken US healthcare system needs all the help it can get. Clearly, it's an impossible scenario, yet American graduates land in low-income countries to advise them on global health issues all the time. I met an African expert recently, and she expressed her frustration about how American quote-unquote kids with little or no experience come all the time to advise her government on what to do about health. So not to say that we need to sort of paralyze ourselves or stop engagements in global health, but I think very important to sort of be conscious and conscientious about our engagements and sort of be really critically self-reflective as we continue our work in global health. So with those cautionary words, let me now launch into the content of my presentation. And here, a shout out to Greg Roth. A lot of this stuff is going to actually come from his and his colleagues' work in terms of global burden of disease. Cardiovascular disease, as I'm sure you all know, is a global problem. Does my cursor work up here or no? Basically, this heat map shows each box, the square area of each box is proportional to the mortality burden from a particular cause around the world. Everything in blue are the non-communicable diseases, cardiovascular, diabetes, cancers, etc. Everything in red are accidents and injuries. And interestingly, this is the most recent 2024 global burden of disease. And so data from 2021, when COVID was obviously big, and you can see COVID was a huge contributor to global mortality during that year. Everything in green are accidents and injuries. And again, they have this gray box, which is new for this particular year, which is like other COVID-related diseases. But what you can see actually is that the blue boxes, non-communicable diseases, predominate in terms of attributable mortality. And if you look in the upper left-hand corner, cardiovascular diseases amongst those are the largest burden. And then if you combine ischemic heart disease and stroke, the number one cause of disease around the world. But not only is cardiovascular disease a problem globally, it's even particularly a problem for low resource settings and low and middle income countries worldwide. So this bar graph shows death rate along the y-axis in different regions of the world along the x-axis. And it's obviously a fairly complicated graph. An image shows a bunch of different information. You can see there's variations in overall sort of mortality across the regions. But what I want you to pay attention to is the sort of like medium blue cardiovascular disease mortality. And what you can see here is in many regions of the world, as you go across, actually cardiovascular mortality rates are higher in low and middle income countries than they are in high income countries like Western Europe, the US, Australia, et cetera. And so what has traditionally been thought of as a disease of the rich or an epidemic of rich, high resource settings is actually even more of a problem for low resource settings worldwide. What are the costs of global cardiovascular disease? This was now put together about a decade ago by the World Economic Forum and World Health Organization, basically estimating the cost of the next 3 decades to various causes of various categories of non-communicable diseases. And what you can see here is that the total cost over the next 3 decades was estimated to be about $47 trillion. And so I just want you to focus on the order of magnitude, $47 trillion attributable to these non-communicable diseases. Cardiovascular contributing a third of that cost, $16 trillion. Very importantly, actually, mental illness also contributing a third of that, $16 trillion. So I won't be discussing much more about mental illness today, but just to emphasize and reaffirm that mental illness is a huge issue with respect to mortality, morbidity, and economic burden around the world. But just to emphasize again that cardiovascular disease contributing nearly $16 trillion to global economic costs. It's not only a problem at the macroeconomic level, it's also a problem at the microeconomic household level. So this is a sort of a compilation of studies from around the world looking at household level expenditures related to non-communicable diseases. And there's this concept called catastrophic health expenditures, essentially a significant proportion of your family's monthly household income being spent on healthcare related to non-communicable diseases. And so there are different definitions of catastrophic health expenditures, as you can see here along the x-axis, 30% of household income, 40% of household income, et cetera. But regardless of the definition, you can see in general, nearly 30 to 40% of households around the world experience catastrophic health expenditures due to non-communicable diseases. And if you think about even your own monthly salary or your family's monthly income, and think about like 30 to 40% of that being shoveled over to healthcare just for non-communicable diseases, it's a huge and really unbearable economic burden at the micro household level. Another way to think about the costs of cardiovascular disease was put together by a colleague up at Harvard, Tom Gaziano, where he estimated that the cost of hypertension was around $400 billion per year. Importantly, 20% of that cost was due to treatment. 80% of that cost is actually due to untreated, uncontrolled hypertension leading to complications such as ischemic heart disease, stroke, heart failure, kidney disease, et cetera. And so many people will say, okay, fine, Dr. Vedanthan, cardiovascular disease is a big problem around the world. Fine, it's going to cost a lot of money, but you know what? It costs too much money to actually treat it. My response is it may be costly to treat, but it actually is much more costly to not treat and to allow the manifestations of uncontrolled elevated blood pressure to manifest. So what does it actually cost to treat? And here, traditionally, the community has divided into two different groups, population level interventions and individual level interventions. Population level interventions being those that try and improve risk factors at the population level, diet and physical activity, substance use, et cetera. And what you can see here is that the cost is in the order of the billions. And so whereas the cost of manifest disease was in the trillions, the cost of actually preventing disease at the population level is in the billions. It's much less costly to prevent. At a per capita level, in some low-income countries, it's less than a quarter per capita per year. And so it's really an amazing low-cost way to try and improve health. Even at the individual level, where you're going out and screening people for cardiovascular risk, screening people for cervical cancer, et cetera, the cost, if you look on the y-axis, is still in the billions. And so again, thinking about early detection, early treatment, early referral into the health system is very important rather than allowing these diseases to manifest and complicate. The other debate in the literature historically has been, should you focus on prevention or should you focus on treatment? And some elegant work by Simon Capewell and many colleagues from around the world has shown that about 50% of the changes in cardiovascular mortality are due to acute treatments, cardiac care units, caths, cardiac catheterization, et cetera. But about 50% of the changes are due to changes in risk factors such as lipids, diabetes, et cetera. And so really, it's not a choice between one or the other. You need both treatment and prevention. That's important. The challenge is that when you look around the world, there's a huge care gap. Less than 10% of individuals who have had a stroke are on evidence-based therapy, and less than 15% of individuals who've had a myocardial infarction are on evidence-based therapy. And so there's a huge care gap, as you can see here. When you look at hypertension, there's also a drop-off in the care cascade. When you look at those who actually have hypertension, amongst those who've ever had their blood pressure measured, amongst those who've actually had confirmed diagnosed hypertension, amongst those who have actually initiated treatment, and amongst those who are actually controlled, there's a drop-off in that care cascade in literally every single region of the world. Part of this is due to poor availability of cardiovascular meds. This is work by Rasha Hatib and others, where they've shown that in some low-income countries, in rural areas, less than 5% of pharmacies even stock cardiovascular medicines. They don't even have them in pharmacies. If you were to go there as a patient, you wouldn't be able to find them. Even when they are stocked, they're generally unaffordable. So again, in some rural areas of low-income countries, nearly 50% of a household's capacity to pay, again, that concept of how much of your household's monthly income goes towards medical expenditures, nearly 50% of a household's capacity to pay is taken up by just these four very basic cardiovascular medicines: statins, ACE inhibitors, beta blockers, and aspirin. So again, if you think about your monthly income or your household's monthly income, 50% of that going towards just these four medications, again, it's really an untenable situation. The other challenge in many parts of the world are insufficient human resources for health. So this is a heat map showing physician density around the world. Everything in the lighter colors shows lower physician density relative to the population. And you can see much of sub-Saharan Africa, parts of South America, parts of Southeast Asia, characterized by very low physician density relative to the population. If I were to show you a heat map of nurses, pharmacists, et cetera, it would be very similar as well. So overall, what I'm trying to say is that the global cardiovascular disease burden, you have to really think about what are called social and structural determinants of health, the conditions in which we live, in which we work, and in which we play. There are many, many diagrams and conceptual models related to the social and structural determinants of health. There are several different layers, as you can see, of our lived realities, whether it's political context, socioeconomic context, community and social networks, and obviously our own individual and lifestyle factors. The diagram that we were trying to put together here was to just show these little squiggly lines to indicate that the relationships between these different social determinants of health is nonlinear. And sometimes there are feedback loops, and sometimes they sort of cross across different levels. And so it's very complicated from an analytic perspective. We were also trying to show this delta T that there's a temporal relationship. Sometimes you can have exposures in childhood or in utero that may not manifest until much later in adulthood. And so from even just a scientific data analytic perspective, it can present fairly significant challenges. All of this, sorry, I'm just going to take a sip of water. All of this now brings me to my work in Kenya, which is a country in East Africa. And as Chris mentioned, I've been working with AMPATH Kenya in the western part of Kenya. AMPATH is an acronym that stands for Academic Model Providing Access to Healthcare. It started actually as a bilateral partnership between Indiana University in this country and Moi University in Western Kenya in 1990, but has expanded over the last 35 years to now include a consortium of over 15 different institutions, many of which are shown here. The goal behind AMPATH, an academic global health partnership, is to advance the entire tripartite mission of academic medicine: care, research, and education. But to lead with care, to strengthen care delivery, to strengthen health systems, to improve population health, and then layer on top of that foundation, then meaningful research and capacity building. If you look at some of the things that we've done with AMPATH Kenya over the years, we established one of the first comprehensive HIV care programs in the early 2000s. We've taken care of over 200,000 individuals living with HIV since that time. I think we can lay claim that we were one of the first groups on the continent of Africa to convert HIV from a death sentence into a livable chronic disease. Over the past decade, we have then leveraged that HIV care infrastructure for chronic disease care. So more my wheelhouse: cardiovascular, hypertension, diabetes, cancer, mental health, et cetera, all the while thinking about strengthening health systems, and all the while also incorporating those social and structural determinants of health into the initiatives and care programs. So what I'm going to be doing now is just talking a little bit about my implementation research in Western Kenya. It is not rocket science. These are all very basic questions, as you'll see, but important questions for the populations who live there. So first question we asked ourselves was, how do you actually increase access to hypertension care for rural populations? And as I mentioned to you, the access to care has been a challenge for decades. The previous paradigm was that folks with cardiovascular disease, even sort of uncomplicated but elevated blood pressure, they would have to schlep essentially from the community to the district or the referral hospital. That journey would often take a day. Once they arrive at that district or referral hospital, they have to wait a day to be seen by the clinician because there are hundreds of patients there waiting to be seen. Then another day to come back to their home. So imagine every month, it's 3 days out of their month to travel, to be away from work, to be away from family, to figure out accommodation, to figure out meals, et cetera. It's an incredibly challenging paradigm. So what we decided to do was to leverage dispensaries that were staffed by nurses, small little health facilities located in the villages nearer to the community, so that nearly 70 to 80% of individuals with fairly uncomplicated hypertension could be managed there locally, and only the challenging cases would have to be referred up. Obviously beneficial to the community and their populations, but also actually beneficial to those central district referral hospitals because they would be now less burdened by the numbers of people trying to access care at those facilities. And really this, we needed to attack the entire care cascade or the entire public sector health system in Western Kenya to establish this chronic disease management program, all the way from level 1 at the household level, again, all the way up to the centers of excellence at the referral hospitals. And here I wish to give a shout out to my colleague, Mima Kamano, pictured here on the left. She's a physician in Kenya who really started this chronic disease management program. Her nurse manager, Deborah Tulienge, who for several years was her right-hand person in this program. Really, without their blood, sweat, and tears, I wouldn't be here in front of you today. So I just wish to say thank you so much for the efforts that they've put in to really make this happen. In the context of implementation research and global health, we talk a lot about stakeholder engagement and needing to make sure that sort of people at all different levels of the community are aware of what's going to happen and are able to sort of take into account their preferences and priorities with the work that we do. So how do we actually engage stakeholders? So we had to go to the Central Ministry of Health. We had to create a special memoranda of understanding in order for us to be able to do so, because we were doing things that were quite radically different in Western Kenya than what was the norm. So we had these formal, document signing ceremonies, et cetera. But also, very importantly, we had our staff who would actually go out to the communities, go out to the villages, go out to the people's homes to be able to sort of dialogue with them and figure out what their needs and priorities and preferences were. And you can see here the challenging circumstances that our workers had to go through. But imagine, again, the populations and the communities and the individuals who have to deal with these conditions on a day-to-day basis. The next question we asked ourselves was how to ensure a consistent, secure medication supply. As I mentioned to you before, access to medicines can be challenging. So one of the innovations that my pharmacy colleagues came up with is called the revolving fund pharmacy, where essentially you give an initial seed donation of either medications or funds to procure a certain allotment of medications. You store them then at these local dispensaries, those rural pharmacies. You sell them at cost with a little bit of markup in order to ensure sustainability. And then with that revenue, you're able to replenish inventory in essentially a continuous revolving cycle. It's almost like giving farmers seeds in year one, allowing them to plant. And then from that harvest, they're able to continue farming continuously after that. So this idea of a revolving fund pharmacy to try and remove the reliance on external support. And what we were able to show is that literally almost immediately after we initiated the revolving fund pharmacy, the availability of medications skyrocketed. So prior to the revolving fund pharmacy, availability was in that 30 to 40% range, as you can see on the far left. And immediately after, it went up to above 90, 95%. We've been able to maintain that level of availability now for many years. This sort of Sankey diagram shows what I like to sort of describe as contextually appropriate solutions. So we started off with model one of the revolving fund pharmacy shown in the upper left-hand corner. And in the middle, we're trying to attack all 6 levels of the public sector health system, level 1 through level 6. So what you can see here is that model 1 pharmacies, but we're able to supply level 3 and level 4 of the public sector health system. So in order to be able to both supply the larger facilities, we have to iterate to model 2 in order to be able to supply levels 5 and 6. And we had to further iterate to model 3 to be able to supply those smaller dispensaries that I was referring to at the very beginning. And so the idea was that we were able to now supply the entire public sector health system with medications that are shown on the far right, cardiovascular and diabetes medications, basically showing that we were able to supply in this year, 2018, nearly 6 million doses of medications to a population that previously had 0. So really quite a remarkable implementation by our pharmacy colleagues. The next question we asked ourselves was, can nurses actually lead hypertension management? So as I described, we were trying to use these a fifth of the size of this room, divided into 3 little rooms, 1 room for intake, 1 room for examination, 1 room for storage of supplies and materials. Here's one of our nurses who was staffing that dispensary that day. But at the time, and this is actually true still in many parts of the world, it is illegal for nurses to prescribe blood pressure medications. And it is illegal for nurses to be the primary sort of caretakers or the primary providers, clinical providers for hypertension. So what we were doing was, again, radically different. We had to secure very special permissions from the government, et cetera, to be able to show, or to test at least, whether nurses could safely and effectively manage hypertension. And I'm happy to say that we were able to demonstrate that they can, actually. So shown here in red are patients taken care of by our nurses. Shown in blue are patients taken care of by their clinician counterparts. And what you can see here is that the blood pressure decline was equivalent in both groups. In fact, if anything, the blood pressure decline was most in the first 3 months and then maintained afterwards. And you can see here, if anything, that the maintenance of that blood pressure decline was actually superior amongst patients taken care of by nurses than by clinician counterparts. So this is one of the first studies to really show that nurses can be primary providers for hypertension management. The next question we asked ourselves was, can technology support hypertension management? And here I have to take you back to 2010, 2011, when Androids and iPhones just came out. Okay, so now it feels like sort of old hat, but then it was like sort of, again, a very revolutionary idea. And again, I want to sort of take you on a little bit of a detour to what's called design thinking. The idea behind design thinking is to complement what we learned traditionally in school, which is analytic thinking using deductive and inductive reasoning, with what I like to call abductive reasoning, thinking outside the box in order to rethink the problem and rethink solutions. So my favorite example of this is the classic elevator problem. Like if you go to any medical center, you go to a big hotel, at the elevators, you're like waiting forever. And so you can do all sorts of engineering solutions based on deductive and inductive reasoning. You can make them faster, you can make them more responsive, you can have them start at level 10 or whatever it might be, but there's always a non-zero wait. Then someone came along and said, you know what, maybe the waiting is not the problem. Maybe it's that people are bored. Let's try and address the boredom. So they put a big mirror at the bottom of the elevator bank. All of a sudden, people are like combing their hair, they're doing their makeup, they're checking other people out, and the boredom went away. And now if you look around at all these fancy hotels, they all have mirrors at the bottom of their elevator banks. The 21st century version of this obviously are those like electronic screens with like news and weather and whatever. But the idea is the same. Rethink the problem in order to rethink the solution. So when we went to these nurses in these rural dispensaries to try and train them on hypertension and diabetes management, we realized that their lives were full of paperwork. Paperwork, paperwork, paperwork. They had to do paperwork for the clinic. They had to do paperwork for the district. They had to do paperwork for the National Ministry of Health. There was so much paperwork that they had to do that they barely had enough room on their little tables for even the small little blood pressure cuff or glucometer that we were trying to provide to them. So at the time, we came up with what we thought was a pretty cool, again, still paper-based solution where you could track blood pressures over time. You could sort of change treatments depending on blood pressure levels and combine it with this integrated record-keeping system, all sort of contained in one small box. But again, as I described, Androids were just coming out, iPhones were just coming out. And one of my team members was like, hey, let's move this onto the phone. And at the time, and again, nowadays, it feels like, you know, sort of ancient history. But at the time, you didn't know that if you sort of clicked a button on the iPhone or on the Android phone, would you actually trust that the phone would receive that information properly, whether it was age or sex or whatever it was? Could you then subject that information to a little bit of logic? Like if the blood pressure was 170 by 110, escalate therapy. If the blood pressure is 110 by 70, maintain therapy. That sort of decision support logic to help support our nurses. Again, unknown. And then finally, could you take a cell phone that was in a rural area of Western Kenya and sync it with the central electronic medical record at the central referral hospital? Also unknown at that time. Well, happy to say that obviously the technology evolved, our implementation evolved, and we've been able to have now several iterations of this. And again, if you think about now Google Maps or whatever that driverless taxi thing that Chris was referring to in San Francisco, et cetera, like it feels like it's a whole new world. But at the time, it was quite revolutionary. The next question we asked ourselves was how to incorporate social determinants of health into hypertension care. And what we realized was that nearly 70% of our population in Western Kenya was either unemployed or earning less than $50 per month, so earning less than $1.50, $1 a day. Okay, so really to severe levels of poverty. We also saw that food insecurity was associated with difficulty accessing care. So the more food insecure families were, the more challenges they had with accessing care. So again, it brings me back to this diagram of the social and structural determinants of health. And what we were really focused on was thinking about the socioeconomic sort of situation of people with poverty. And we borrowed from the tradition or the practices of our HIV colleagues where they had addressed the same issue. So amongst their patients who were having challenges with their financial situations, they were able to find them sort of opportunities for employment here in textiles, here in agriculture. And over time, that had evolved into what are called guichet groups, group integrated savings and health empowerment groups, essentially microfinance groups, patients living with HIV essentially about 20 people like this coming together, really trying to address their financial concerns and try and increase their liquidity, increase their ability to either pay off fees as shown on the right or invest in their small businesses as shown on the left in order to improve their economic circumstances. And then at the same time, treat them for their HIV. So we said, let's do that now for hypertension and diabetes. And so we started this trial called the Bridging Income Generation with Group Integrated Care Trial, BIG-PIC. And the idea was essentially that you bring people together with diabetes and hypertension into these groups, actually address the issue that they are particularly concerned about. They're not concerned about hypertension, diabetes, medications necessarily that are going to prevent cardiovascular events 30, 40 years from now. They're interested in making sure that their kids have food at the table, that they have clothing, et cetera. So let's actually address the issues that they're concerned about, which is their financial situation. But while they're there, let's also now take care of their diabetes and hypertension in these group medical visits, ultimately, hopefully leading to cardiovascular risk reduction. We engaged in a human-centered design process to be able to develop this group model. Anyone who's done human-centered design really knows that you have to bring together, again, sort of representatives from a variety of different stakeholders. So pictured here are folks representing microfinance, nursing, village leadership, nursing, pharmacy. We had our visiting faculty from Duke who was there at the time. We prototyped, we got community feedback, we iterated, and we finally were able to develop our group medical visit microfinance model that we then subjected to a 4-arm cluster randomized controlled trial. And what we were able to show was that the group medical visit microfinance combined arm on the far right did actually lead to better blood pressure reduction than usual care. The challenge was statistically, we have a 4-arm cluster randomized controlled trial. We had to then control for multiple comparisons. So rather than a 95% confidence interval, we needed to actually satisfy a 98.7% confidence interval. And as a result, we just barely crossed zero. So it wasn't a slam dunk. But if you look at folks who actually did attend the groups actively or did have severely uncontrolled hypertension at baseline, they did benefit from the intervention. We've also looked at cost effectiveness analysis. And here, actually, my economist, Eric Finkelstein from Duke, did a very interesting thing where he was able to show that it's not just a yes-no answer in terms of cost effectiveness, which is a lot of times what people do in these cost effectiveness analyses. It actually is really also related to willingness to pay. And if you're willing to pay only a small amount of money here, let's say $1,000 per disability adjusted life year gained or averted, basically then it's usual care that's going to be, quote unquote, the most cost-effective solution. If you're willing to pay a little bit more, somewhere between, let's say, around $2,000, then you can see here that in green, it's the group medical visits. And if you're willing to pay even more, then the group medical visit microfinance model. So it depends on not just cost effectiveness, which gives you the sort of like incremental cost effectiveness ratio, but really, what is it? What is the impact on the budget? Here, the public sector budget, and what is the sort of input of the willingness to pay. The other thing we looked at with BIG-PIC was social network changes. What we thought was that if we bring people together in these microfinance groups, maybe we would increase a sense of cohesion, a sense of trust, a sense of belonging. And could those social network changes then relate to some of the blood pressure changes we saw? And what we saw here is that on the far left at the baseline, people were in these dyads and triads. They had only one person they knew or maybe two people that they knew. And by the end, actually, their social networks were much, much stronger, as you can see here pictorially represented. And we are in the process now of doing those analyses, and they do show that these social network changes did actually relate to some of the blood pressure changes we saw. The next question we asked ourselves was, how do you improve the affordability of procuring hypertension medications? So there's the cost of the medication, but also equally important, or perhaps even more important, was the cost of transportation to go pick up those medications. What we realized was that people were saving money to, let's say, buy their medicines, but then there was the like marginal expense of the transportation required to go to the pharmacy or to go to the clinic. And that was the barrier that was then limiting them from being able to access their medications. That adherence, and here the sort of adherence score, as you increase, is actually worse adherence. That worse adherence was associated with increased transportation costs. So we said, let's try and figure out a way. Again, the whole theme of this talk, I'm hoping, is not just to document problems, but really to think about solutions. And so the idea was, let's try and now address this issue. and let's take medications to the patients. So we came up with, again, this innovative model of community medication delivery using peers who will have hypertension themselves to go to house, so to pick up the medications from the pharmacy and actually go to the households, dialogue with the patients, provide them some peer coaching and psychosocial support, connect them to the clinician if necessary using telemedicine, but also give them their medications. And what we were able to show in our pilot work was that the greater number of deliveries that we were able to successfully do, the better was their adherence and the better was their blood pressure reduction. And so we're subjecting this now to a formal cluster randomized controlled trial as well. The next question that always comes up is, can lessons learned in Kenya be applied elsewhere? So people are like, again, Vedanthan, great, you're doing all this work in Kenya, but what does it matter to us? What does it matter to the United States? What does it matter to the rest of the world? But I'm happy to say that the answer is yes, the lessons can be applied elsewhere in Kenya. And here I wish to thank Chris and his colleagues for leading this trial called Extra CVD here in the United States, in Ohio and in North Carolina, trying to reduce cardiovascular risk amongst patients living with HIV. And many of the elements of this Extra CVD trial that took place in this country were informed by lessons and experiences that we learned in Kenya: nurse management, use of technology, social networks, process evaluation, et cetera. And so there's a term called reciprocal innovation, which is about sharing of ideas and lessons across different geographies or across different settings. And so Chris and I, along with our colleagues, are writing this up with respect to some of the lessons that we learned in East Africa that we've now applied to the United States as well. I'm going to pivot here a little bit, that as I was driving to these rural clinics in Western Kenya, I would oftentimes pass houses like this, where smoke was emanating from the house. And so as I was driving, I was just reflecting to myself, like, well, imagine if I can see the smoke emanating from the house, what must it be like inside the house? And so it really got me thinking about indoor air pollution. And again, thinking about, again, that diagram of the social and structural determinants of health, here thinking about environment. And what we showed over time was actually that air pollution, both indoor and outdoor, is actually an important contributor to global cardiovascular mortality. We started to try and put this onto the map a decade ago. And I think I have a slide here. Again, I want to thank Greg and others for showing that that actually now air pollution is one of the top causes of global cardiovascular mortality, really bringing, sort of highlighting the importance of that risk factor as well. When you think about air pollution, many people think obviously of like pulmonary toxicity or potentially cancer, but the reality is that the greatest cause of mortality and morbidity from air pollution exposure is actually cardiovascular disease, and that's very important to recognize. As a result of the science and as a result of the advocacy, actually WHO expanded their risk factor network, the conceptual framework. They used to sort of say there were 4 main risk factors, and then recently they actually added a 5th, which is air pollution, as a result of all of both science and advocacy. There are many, many mechanisms related to the connection between particulate matter exposure and cardiovascular disease. I don't have time to go into it in detail here today, but there are many, many pathophysiologic mechanisms that connect the two. I always, again, bring it back to not just describing the problem, but describing solutions. So based, again, on my sort of practice as a clinician, how can I, as a clinician, how can I, with my patients, try and improve their health outcomes? And so one of the trials that we're doing in India is trying to look at air purifiers inside people's homes who have heart failure to try and improve cardiovascular health. We've done some pilot work that shows that our air purifiers are able to reduce PM 2.5 levels almost immediately to safer levels. And we're doing this study in 3 different sort of locations in India: Delhi, Ludhiana, and Thiruvananthapuram, with different ambient levels of air pollution. And so the question we're going to ask ourselves is, you can try and reduce pollution in the home, but if you're surrounded by a ton of pollution outside, will it make a difference or not? And so this study hopefully will be able to shed some insight into that question as well. The other thing that we also decided to do was to try and say, again, as a clinician, what can I do with the patient in front of me, right? When we think of air pollution, and here this was written for wildfire smoke, it feels like these are like sort of like much larger events that are happening that are like beyond my control, beyond my patient's control. But what can I do as a clinician? What can I do with that patient in my office or my clinical setting? And really thinking about risk assessment, thinking about those who are highly exposed either to air pollution or wildfire smoke, thinking about those who are additionally susceptible, meaning certain age groups, pregnant women, certain comorbidities, et cetera, who may be more susceptible to the same level of particulate matter exposure, and obviously the intersection of those two being the highest risk group. We also came up with different recommendations, both individual level, health system level, and community level, both for prevention and preparation for wildfire season, as well as for what to do when wildfire season is actually happening. And finally, we've evolved this over time to think about climate cardiology, to sort of really think about the interventions that we can do, shown here in the middle, that can both be beneficial to cardiovascular health on the left, but also can be helpful with respect to climate change and air pollution emissions on the far right. So things like obviously transitioning from high red meat to plant-based diets, expanding green spaces, transitioning from vehicular to active transportation, clean renewable energy, clean cook stoves and fuels for cooking and heating, and resource efficiency in healthcare can have beneficial impacts, again, both on cardiovascular health and health in general, and obviously can have beneficial impacts on the environment as well. I wanted to give a shout out to another University of Washington collaborator who co-wrote this paper with me, Chris Ebi, from the university here, is doing amazing work actually at the intersection of climate change and health. I wanted to just also just give a few words about this new initiative that we're doing in Ghana, which is called AMPATH Ghana. All of the work I've described before has really taken place in Kenya with that AMPATH collaboration, as I mentioned, based on many of the experiences that we've had there, generally quite positive. Leadership of AMPATH said, let's try and replicate the same approach to global health in other places. So we now have AMPATH Ghana, anchored by NYU, AMPATH Nepal, anchored by Mount Sinai, and AMPATH Mexico, anchored by UT Austin. In Ghana, we are partnering with University for Development Studies, Tamale Teaching Hospital, the Ghana Health Service, and the AMPATH Consortium to, again, do the same thing, to advance the entire tripartite mission of academic medicine, care, research, and education, to lead with care and piggyback on that care foundation, then with meaningful research and education. Pictured here are the executive leadership of both the medical school and the hospital. Just to give a shout out to both Stephen Tiberi and Adam Atiku, who have been incredibly supportive of these efforts and really helped pave the way for many of the things that we've done. I wanted to sort of talk about three words. When I think about our work in AMPATH Ghana, and again, when I think about engagement in global health, I think about friendship, transformation, and equity. One of the things that we talk about a lot in AMPATH is that we are trying to build long-term collaborative relationships between collaborators across both sides of the ocean that are grounded in mutual respect, mutual trust, and mutual benefit. But it actually even goes beyond that. We like to hang out with each other. We like to do things together. We look out for each other. We celebrate each other's successes and the births of children. We also are there to sort of provide a shoulder to cry on when things are not going well. And so it's really beyond just relationships grounded in trust, respect, and benefit. And really, we're trying to aspire towards friendship that happens across these global communities. We are also working towards transformation. And this is a picture of an electrocardiogram from Kenya when I was there in 2005, 2006, of a gentleman, middle-aged gentleman, who came in after having sung at his church choir with some epigastric pain. And he came to the casualty or emergency room and was treated for 48 hours with pain killers, with H2 blockers, with proton pump inhibitors. And finally, after 48 hours, someone was like, hey, maybe we should actually get an electrocardiogram. And unfortunately for this guy, you can see it's showing massive ST elevation MI. And this gentleman actually died within a half hour, an hour after this electrocardiogram was done. So that was standard of care back in 2005, when somebody who with those symptoms should have had an ECG within 5 minutes, essentially, was getting one after 48 hours. Well, I'm happy to say, and this is as a result of many, many efforts led by colleagues at Duke University, that we have transformed cardiovascular care in Western Kenya. We have a CCU now led by Kenyan cardiologists. We are doing invasive procedures such as pericardiocentesis, stress echoes, a non-invasive lab, transesophageal echo. Here you can see Jerry Bloomfield, one of our colleagues who's done work there. We're doing open heart surgeries now in Western Kenya. So if I look at the sort of landscape of cardiovascular care there now, 2025, relative to 20 years ago, we have transformed cardiovascular care in Western Kenya. And we're going to engage in the same transformation of health systems and population health in northern Ghana as well. And so we're doing things like a chronic disease management program, a clinical pathways program to improve quality of care, and a molecular diagnostic laboratory that we've installed there that's going to revolutionize molecular medicine in the country. Importantly, however, we are not just transforming care in Kenya, Ghana, et cetera, but we're also transforming the practice of global health at NYU. And we're trying to transform the practice of global health on this side of the ocean as well. And those of us who engage in this work seriously recognize that there's an internal transformation that happens as well, whether you call it psychological, spiritual, whatever. There's an internal transformation that happens as well. So there's an internal transformation and an external transformation that is happening on both sides of the ocean. So transformation. The other thing that we are working actively towards is equity. Equity, what I like to call in process, and equity in product. So in process, every single thing we do in Ampath Ghana is co-produced, co-created, co-led by colleagues from NYU and from University for Development Studies and Tamale Teaching Hospital, whether that's at the upper executive levels or even every single initiative or trainee exchange program that we have. So equity in process. But also we are trying to do equity in product, which is that we're not, again, the whole theme of my talk is not just documenting health disparities, we're trying to address them and trying to make them better. And so we are working in northern Ghana where we have, again, fewer physicians per population, where we have higher infant mortality rates, we have higher climate vulnerability in the north, we have higher food insecurity in the north, but we have many initiatives that are going around trying to address all of those issues. So a final concept that I just wanted to put forward here, and I wish again to thank Greg for actually helping put this together, is this concept of what I like to call proactive prevention, which is to take actually populations and communities who are currently low burden in terms of disease burden and actually proactively target preventive efforts on them. So rather than being reactive in terms of prevention and waiting for people to develop hypertension or diabetes before you start to counsel on lifestyle modification, et cetera, actually take kids who are healthy and maintain them healthy. Take populations who actually currently have a low burden of disease, put in place the structures, the policies, the practices, the behaviors in order to avert actually the epidemiologic transition that is otherwise going to happen. So proactive prevention. I have a couple more minutes, so I'm going to go into sort of a touchy-feely aspect of my presentation, especially because there are several trainees who are here today. This is just a final sort of few thoughts on reflections on global health or reflections on my work. The first lesson that I've learned is to quote unquote know your DNA, recognize who you are. So these pictures are actually from the mid-1990s in the United Kingdom in Newbury. So I was a student there, and there was this area called Newbury and a beautiful forest, and the government was planning to put a highway through there. So there were many, many protests. People were marching, people were like chaining themselves to trees, people were actually living up in the trees and have this like incredible system of like pulleys and buckets and all that sort of stuff to be able to like take care of all the waste. I never lived up in the trees or chained myself to the trees, but I was involved in the like marches and stuff like that. But I realized that, you know what, it just wasn't me. That if I needed to make my mark on the world, I needed to figure out my own way to do it. I was super excited and I was cheerleading those guys who were doing all this direct action, but it wasn't me. My DNA wasn't resonating with that. So I needed to find my own path. But equally important is to recognize that the quote unquote entire spectrum is necessary. That you'll play your one small part in this world, but there are many other interconnecting parts being done by other people that are very important to recognize and to respect as well. So this is in the context of access to medicines. Again, you need multilateral agencies such as the WHO, WTO to sort of set the rules of the game globally. You need pharmaceutical companies to actually produce the medicines. You need the procurement bodies, and you ultimately need the end users, the clinicians like myself, the pharmacists like Sonak Pastakia, shown on the far right, to be able to actually give the patients their medications. But what am I going to be able to do unless I have the pharmaceutical company who actually produces the medicines, unless I actually have a procurement system that actually is able to get the medicines to us, et cetera. So really the entire spectrum is necessary. The next lesson I've learned is to quote unquote get started, make mistakes, but self-correct. So this is a picture of my friend and colleague, Sunita Krishnan. We were both students, she at Berkeley, myself at UCSF. Actually, I was also at Berkeley for a little while. And we started a women's health program in southern India while students. We were totally naive. We had no idea what we were doing. We made a bunch of mistakes. But we've learned from those mistakes, and many of the lessons that we've learned, I've been able to apply in the work that I've been able to continue doing since that time. And so one of my mentors always said, if you never get started, obviously you're not going to help anybody. And if you're so paralyzed and frozen and fearful of making mistakes that you sort of paralyze yourself, you're also not going to help as many people as you should. And if you make mistakes and obviously don't correct yourself, you're not doing as good a job as you should. So so get started. Don't be afraid to make mistakes, but then self-correct. This is my mentor, Joe Mamlin in Kenya, really an amazing person and really an inspiration. And one of his key phrases has been this: dream all night, but work all day. And he used to tell me that if you dream without working, nothing will ever happen. And if you work without dreaming, the work is not meaningful. So dream all night, work all day. I like to add, make some time for play, because I think it's important to take care of yourself. So dream all night, work all day, and make some time for play. Recognize that the journey is larger than you. So this is a picture of my two daughters, Leela and Asha. And the journey is not going to end with me. I'm passing the baton on to them. We as a faculty community are passing the baton on to you, that we will carry this baton for as far as we can, but we'll be dependent on you to continue taking it on onwards. And so the journey is larger than you. And then finally, in the end, everything will be okay. And if it's not okay, it's not yet the end. And I think that's just a very nice sort of way to think about life in general. So in conclusion, cardiovascular disease and its risk factors are a global problem. There are many significant treatment and prevention gaps, but I'm hoping that I've shown to you today that you can translate those challenges into opportunities, really thinking about the social and structural determinants of health, including climate change, air pollution, and the intersections with cardiovascular disease. A slide here to just show several of my collaborators, probably not all inclusive actually, so thank you to everybody, and thank you here.
Well, Raj, that was incredible. Thank you so much for a really whirlwind tour of all kinds of things. And I'll start with a comment as people are gathering their questions. You said implementation research is not rocket science. And on the surface, it kind of seems like that, right? We know what works to treat blood pressure. It doesn't seem like rocket science. And yet, you just showed how complex it is, right? So when you get under the surface, there's all kinds of stuff that we need to address. What skills are necessary for those who may be interested in having a career in implementation research? Should they be going out and getting an MPH? Should they train in other methods? What are some of those key skills that you need in implementation research?
Yeah, great. Thank you so much, Chris. And and I agree. Maybe I was a little bit premature in saying that it's not rocket science, because there's obviously a lot of important work that has been done in the field of implementation research that has shed many and given us many insights into actually trying to make things happen. I think the key is and I try and do this both in my clinical practice, but also in my research, is to really get into people's lives, to really get a sense of what their lived experience is. And I think that's very important. If you look at whatever it is that we've gone through, whether it's even COVID over the last 5 years, and you look at a lot of the challenges that we've faced in terms of even our COVID response, a lot of that is driven by sometimes not actually recognizing, what it is that matters to people, whether it's about being able to go to church, or whether it's about being able to go to Thanksgiving dinner with grandpa and grandma, or whether it's about being able to connect with people, or whatever it might be. All of those things actually challenged the COVID response. And I think it's very important to sort of recognize that, that we need to sort of really tap into people's lived experiences. And so whether it's about poverty, whether it's about environmental conditions, whether it's about values, whether it's about what you're willing to sort of be motivated to take action to do as a health community, as a health professional community, as an implementation science community, I think it's very important to recognize that. Now, in terms of where does that go in terms of sort of future training, et cetera, the field of implementation science is at a level of maturity now, which it wasn't when I first started. And so there are now very formal tracks. Actually, University of Washington has amazing resources for implementation research. And so folks who are interested here, I would say tap into the local community and the local resources and faculty you have. You have an amazing array of resources. There are many training programs there. But I think the most important thing, just like I was describing about the quote unquote entire spectrum of necessary, I have a separate talk fully on implementation research as a transdisciplinary exercise. The reality is that in order for implementation research to work and in order for implementation to work, you really need all sorts of different players. You need obviously the health professionals, but you need the technology people, you need the qualitative people, you need the stats people, you need the economic folks. And so my advice really is to the trainees, figure out what drives you. Figure out what keeps you up at night, what wakes you up excited in the morning, what's going to keep you motivated during the day. Because in the end, all of it is going to be important. Whether it is that you're working on, sort of being the best clinician you can be, or figuring out the sort of like costing analyses, or even thinking about the sort of humanities of it, and like thinking about what meaning people attribute to various events that are happening in life. All of it will be important.
Great. Are there any questions? Dr. Roth.
Yeah, thanks for just really a fascinating presentation. I wanted to ask about the environment in different countries as you think about how these kinds of approaches might work elsewhere, and how much of this requires interest and energy from a local academic medical center versus the local health system versus the Ministry of Health, and sort of how those different actors sort of balance, and how that might make it sort of a good opportunity to try and implement versus a more challenging one.
Yeah, thank you. Very important question, especially in the context of my work with AMPATH and history with AMPATH, which is fundamentally an academic global health partnership between academic medical centers across both sides of the ocean, then trying to work in partnership with either the health system or the public sector health system and with Ministry of Health. In many countries, Ghana and Kenya included, but many other places also, many of the universities are answerable to the Ministry of Education. The health system is answerable to the Ministry of Health. And so they're sort of answerable to sort of different vertical chains in the org chart. Ultimately, the main connecting point is Ministry of Finance that helps determine where the money flows. That being said, the experience we've had in AMPATH Kenya is that academic medical centers and the partnerships that you can develop between academic medical centers and health systems can be engines of innovation, can be engines of discovery, can be engines of testing out new things that can be then sort of demonstrated, tested, evaluated, and then if able to be shown to be effective and affordable, et cetera, can then be more widely implemented. So there are many examples, as I've shown you in Kenya. There are many examples in other places as well. And I think even in the United States, if you look at our academic community, academic government partnerships, there is a potential, a promise for that type of work to happen as well. It's obviously not seamless. There are many, many tensions and challenges. But again, I think one of the themes that I've hoped to get across today is that you shouldn't just stop at describing the challenges. You should take the challenge and think of it as an opportunity. And what's the opportunity in that challenge? And I think even in the context of what Chris said today, obviously the current situation that we're living in now has, it's almost like you've sort of taken the cookie jar and like sort of shaken it up. And there are going to be many sort of challenges in the context of that shakeup that has happened. But in the context of that, there will be opportunities. And so I think it's very important to think about the opportunities and quote unquote, how can the phoenix rise?
Dr. Upara.
Thank you very much for the talk. I'll speak on the microphone. Thank you very much for the talk. I thought it was very insightful and very well done. In regards to hypertension treatment in Kenya, the nursing staff that you work with, did they require any additional training to treat the hypertension? And if so, what type of training did they get?
Yeah, thank you so much. So I did show a slide a little bit about the training, not exactly the training that we did, but definitely they did require training. especially in Kenya. But again, this is going to be a little bit context specific. Most of those nurses, their scope of work and their training was related to a certain sort of set of things that they were expected to do, whether it was childhood vaccinations, whether it was antenatal checks, et cetera, et cetera, et cetera. We were definitely adding to their scope of work. So there was training that was required in order to do that. There were also negotiations that were required, both not only with the nurses, but also with leadership, to make sure that the things that we were asking them to do, that they were okay with doing so. And so there was training related to hypertension algorithms, training related obviously to medication, both effects and side effects and potential complications, escalation of therapy, the use of technology, when you should refer, a bunch of things that we had to technically go over with them.
Well, we are at time, so okay, I think we're good, probably at time. So we will take your question online and maybe have connect with that person afterwards. But I do really want to thank you, Raj, and thank you to those who are here in the room and to those online. We look forward to doing this again next year for our second annual Global Cardiovascular Health visiting lecture. If you're around, there are some events later today at the School of Public Health and Department of Global Health. We're going to be talking about kind of re-envisioning the future of funding for global health, and a nursing event later this afternoon. So if anyone's interested, please let me know. Thank you.
Thank you again.